Just to get into maternal mortality, that's any pregnancy-related deaths during pregnancy, immediately postpartum, or up to a whole year after pregnancy. And there's many, many factors that influence this. Unfortunately, 60% of maternal mortality can be prevented. When we look at Black women versus white women, there's a 4 to 5 times fold increase of maternal mortality. So it is important to look at why this is happening. So there's many, many factors, education, socioeconomic status, patient-driven factors, hospital-driven factors, but then we get to practitioner-driven factors. And so that's where implicit bias comes in. So when we talk about implicit bias, it can affect the patient-physician relationship. It can affect our treatment plan and our management for our patients. And so this could affect the outcomes of our patients. So it is something that we really do need to look further into.
The other factors, are those different things or are they under the umbrella of implicit bias?
Different things. I look at them as at 3 different areas we can look at. We can look at patient factors, whether patients have access to care, maybe it's a rural area. We can look at patients' trust in their physicians. Some patients, especially brown skin and Black patients, come from a background where they may not feel like physicians are always looking out for them, where their practitioner is not always looking out for them, so they may be less compliant. And then we look at hospital-driven factors. We have to make sure that every patient, like the staff, hospital administrators, are aware of how we can decrease their mortality. So those are 2 different umbrellas, and then you have the practitioner umbrella. So under the practitioner umbrella falls this implicit bias.
So all women have those other factors, but the implicit bias is another layer on top of that, that then is another issue for just Black and brown women because of that. So they have to deal with everything, so it's 10 times worse. Is that the...
Correct, because like I said, the mortality rate is 4 to 5 times higher for a Black woman that's over the age of 30 compared to a white woman. This is, and we can take into account, they've taken into account education, economic status, job titles. They've taken all of that into account, and it's still higher, even when they account for those things. So when we start to look at that, yes, it's access to healthcare and things like that, but there's still another layer. And I'm just glad that you're bringing this up, because many people, this is a really touchy situation, a touchy topic to discuss. And remember the definition of implicit bias. This is not racism. This is not a conscious decision that we're going to treat patients differently. This is just a subconscious way we view the world. And once again, it's made up from who we are, like who we are, where we grew up, like I mentioned before. So it's not like a blame game, so to speak. It's more just an awareness game. We have to all be aware that we come from different backgrounds. We have to be aware that we can't overlook something that we don't understand. And I think when we take time as practitioners to step back and look at each individual patient for what they bring to the table as far as their risk, I think we do a better job.
Black doctors or other minority doctors can also have those same implicit biases as well.
Definitely. It's just something that we have to, I think we all have to overcome. It's not just a certain culture versus another culture. I mean, we all have to overcome it. The biggest thing is looking at every patient for what their risk is, what they're bringing to the table, looking at their medical conditions. How can we lower their chance of them having any problems during pregnancy or after pregnancy? There's different things that we can do to improve or decrease the maternal mortality rate. Like, for example, making sure that when we see patients for their regular annual visits, if there are any red flags, any medical conditions, that we get them kind of managed early. So when I see a patient, if that patient is obese or overweight, I discuss that at that point, at that visit, especially if they're reproductive age, because you never know, the next visit they may be pregnant, or if their blood pressure is a little bit borderline, I bring it up. Do you have high blood pressure? Some patients, oh, no, I don't have high blood pressure. We check it again. If it's high, I give them a referral to their primary care doctor, or I may encourage them to buy a blood pressure cuff at home. These little things that can be overlooked if we're not paying attention, I think are really, really important. And encouraging patients to come in for something called a preconceptual counseling visit, just to discuss, if I became pregnant, what would my risk be? So there's a lot of things that we're doing now that may not have been done in the past to try to decrease that mortality rate.
Can you just speak to just how important therapy is for everyone involved as well?
Therapy is so very important. You know, sometimes mental health is overlooked as far as being a risk factor or something that's really important to make sure we take care of.
For, you know, is that what women, when they're looking for their OBGYN, they specifically seek out, you know, someone who looks like them and have somewhat of the same issues as them, or can they go to other doctors as well?
I think that's a good question, by the way. I think the most important thing is to make sure that you go to a physician you feel comfortable with. This is all about a good patient-provider relationship, no matter what that means. So you want to make sure that the person is understanding you. You want to make sure the person hears you. You want to make sure that you agree with whatever the person is recommending, and you want to make sure that when you walk out the door, all your questions were answered, all issues were addressed, and you feel comfortable with the game plan.
If they're with, you know, there's someone that they're comfortable with, a doctor they're comfortable with, but that doctor doesn't know much that or doesn't realize of their unconscious implicit biases, is it okay for the patient to then be able to let that doctor know?
Yes, yes, and yes. Patients have to be their own advocate. Even if, for example, a patient is at their first prenatal visit, and let's just say this is a Black patient, and their doctor is addressing all the issues of what to expect during the pregnancy. It's okay for that patient to say, you know, I hear that when it comes to maternal death, I may be at more risk for that because I'm Black. It's okay for a patient to say that, and then have that dialogue with their physician and go over that. It's 100% okay. I encourage it, and it makes patients more interactive in their healthcare. It'll make for a better relationship with their physician because they're on the same page. And I think I don't know. I think it's really important to have those discussions, and it's okay. And us as practitioners, we don't feel funny or feel some kind of way when patients bring up things, issues that are concerning to them that they want to discuss.
Thank you for your time.
You're welcome. And thank you for having me on. Thank you for addressing these issues because these are very, very important issues.